everyone hear me? Awesome. I am not using the mic. All right, so as an introduction, my name is Stacy Bello. I'm your local occupational therapy student. Been here since November, so if you have a question, come see me. Happy to help. Today we have a guest speaker who is a podiatrist. This is Dr. Arroyo. She is one of 4 providers at Dallas Podiatry Works. She's here to share some of the common ailments that she sees within her practice and what she's learned over the past 10 years. Please give it up for Dr. Arroyo.
Thank you. Thank you. So yes, Stacy asked me to come and talk to you guys about just general foot and ankle health, things that I typically see in my practice. The objectives of this lecture today is to learn about some of the more common pathologies that I encounter and you may also encounter in your profession or may have experienced some of these pathologies or you may know somebody else who has. Um, Also being proactive and seeking help for you or your clients, customers. Sometimes your customers become your best friends. They ask you for advice, so it's good to kind of guide them in the right direction. And also, it's important to know when to seek professional help so that you can receive optimal care. So I'm going to start talking about overuse type injuries, which are very common. Plantar fasciitis, Achilles tendonitis, retrocalcaneal bursitis, shin splints, metatarsalgia, and stress fractures are some of the most common overuse type injuries, okay? So they're typically caused by excessive or repetitive activity for extended periods without adequate rest, improper footwear, sudden increase in activity level or increase in intensity level, and also biomechanical issues can cause or predispose you to having these types of injuries. So people that have very flat feet or high arches, they're more likely to experience these types of injuries. So I'm going to start with plantar fasciitis, and uh, people that experience this condition, they tend to have pain to the bottom of the heel. The symptoms are typically worse in the morning or after prolonged periods of rest, and they improve after you start walking. After having this condition for about 3 months, it's now considered chronic, and it becomes more challenging to treat. So some of the initial treatments we start out with is a night splint, which is indicated if your pain is worse after rest. Home stretching exercises can also really help, especially calf exercises. Wearing a good arch support can help. At times, a steroid injection if your pain level is pretty high and is very well localized. EPAD and shockwave therapy, which you can see that's the picture here in the bottom. And it's basically like ultrasound based. It's one of the newer treatments, and it literally feels like a hammer's hitting the heel, which can be painful. But it helps bring circulation to the area to get rid of all the inflammation and indirectly help with the healing. It's very common in athletes because there's essentially no downtime. So that is a good treatment option when you have this condition and it becomes chronic. Um, Achilles tendonitis is another very common condition I see in my practice. There's patients typically come experiencing pain to the back of the heel, and it can be worse with increased activity. Conservative treatment is pretty similar as plantar fasciitis. You can take anti-inflammatories, physical therapy. You may have to make shoe modifications, heel lift to take tension off the Achilles tendon, and EPAD, depending on the location of the pain, can also be helpful. If pain is present longer than about 6 weeks, sometimes we have to get an MRI just to make sure there's no tears in the tendon. The treatment option for this is typically debriding or cleaning out the diseased tendon. And sometimes if there is a tear, it would have to be surgically repaired. Retrocalcaneal bursitis is basically when there's inflammation of the bursa I'm sorry, I don't know why the font is so small. But Haglund's deformity, it kind of goes hand in hand. It's also known as pump bump deformity, and these patients typically have a bony prominence in the back of the heel that can be painful with pressure in certain movements, such as running, jumping, squatting, or wearing flat shoes. You may notice redness, swelling, blistering to the area, and sometimes patients get a callus in the area just from the rubbing of the shoe. Um, Surgery or conservative options for this are basically uh, shoe gear modifications. You may have to wear shoes that have a more flexible back to them so they're not putting pressure. Sometimes a heel lift can also be helpful. And if basically the conservative treatment fails, they don't respond, it would be surgery. And surgery is typically more involved than just typical Achilles tendonitis because it involves a lot of times opening, making an incision, removing the spur, and sometimes you have to detach part of the tendon and reattach it. So the recovery is longer than just cleaning out the tendon. Um, and this is a picture of my most recent surgery that I did with this condition. On the left side, you can see this is after surgery, this is before. The difference is you see a lot of spurring here, and clinically it looked more pronounced in the back of the heel. And this is after. You can see that spurring is no longer there. Um, this is a picture of intraoperatively that I took, and it just shows the final repair of that spur being gone and the tendon being reattached. And typically we use like a bone anchor and suture material um, to repair this. Um, uh, Typically patients have to stay off their foot completely for about 2 months or sometimes 6 weeks, and then gradually physical therapy. So recovery can be up to 4 months. So it is important to try to treat it early if you can. So I have any runners in this crowd, people that like to run? So you may have experienced, shin splints or know of somebody that has. It's very common. This is basically people complain of pain to the lower leg, inner part of the shin bone. And it's often caused by repetitive stress on the shin bone and connective tissues that connect the muscle to the bone. It typically starts as a come and go type of pain, and then it becomes more persistent. And patients report more of a sharp, dull ache in the area. And it does get worse after activity. Sometimes they say the pain is worse, not while they're running, but after they finish running. Common causes is if you have an abnormal gait, so people that pronate, which is when your foot rolls inward. Um, Overuse or sudden increase in activity can also cause this. Walking on hard surfaces, vitamin D deficiency, patients have a higher risk of getting this if you wear poor shoes, and then having weak or tight calf muscles. So it's very, very important that you stretch before and after. Um, the treatment for this typically involves orthotics if there is concern of abnormal gait that we need to correct the way that you're walking. Optimizing your vitamin D levels if you're having a vitamin D deficiency. Physical therapy a lot of times can be very helpful. Also, staying hydrated just to make sure that you don't get electrolyte imbalance, which can lead to muscle cramping and pain. Massage therapy can also be very helpful to reduce the tightness, improve flexibility, and the circulation. And the picture here on the bottom, it just shows you an example of an orthotic. It's basically like a liner that you put inside the shoe. And if you look at the difference, it sort of puts the heel in a more rectus position or parallel to the ground. I'm sorry. So that way, um, it allows for the joints to be optimally aligned, and you're not overworking those muscles and tendons, and that's how it indirectly helps prevent shin splints. Metatarsalgia is another very common condition I see. Patients that come into the office with this, they typically complain of pain to the ball of the foot, and it is worse if wearing non-supportive shoes or walking barefoot. At times, the pain may go into the toe, and they may experience some numbness sensation, and the toe may also change position. Typically, we start by prescribing some orthotics with a modification to take pressure off the area. Sometimes we strap the toe. Wearing shoes that have a stiffer sole tend to help. Some topical or medication can also help, and obviously reducing your activity to tolerance. Sometimes, if you don't do that and you keep working through the pain, people can end up with a stress fracture. And stress fracture is when there's like an incomplete break in the bone, and it is caused by repetitive stress over time. So sometimes you repetitive jumping or high impact to the foot. And it can be caused by just fatigued muscles, basically just working through the pain. Improper footwear. Basically, the pain will gradually worsen. You may notice some swelling to the area, sometimes even bruising. And uh, the red flag here is that there is pain even when you're at rest. So, if there is suspicion of that, it is recommended to see a doctor to get an x-ray, because a lot of times it would require to monitor and make sure that the fracture is healing. We treat these by initially, resting, ice compression, elevation, oral anti-inflammatories to help with the swelling, the pain. Sometimes I have to wear a shoe or a cam boot, depending on the location of the fracture. And vitamin D supplements, if you have vitamin D deficiency, can also optimize the healing. Limit activity level. And it typically takes about 6 to 8 weeks to heal a fracture. Um, and another common condition that I see is ankle sprains. Ankle sprains, it's when you roll your ankle and there's a twisting injury leading to pain and swelling. Uh, this may be caused by falling, landing awkwardly, stepping into a hole, wearing improper shoes that lack stability, or sometimes patients like soccer players that they've had multiple ankle injuries, they have instability of the ankle, so it's a higher chance of their ankle giving out and re-injuring the ankle. Um, so there is pain with walking, bruising when it's more acute injury, and then we always recommend getting an X-ray to rule out any fracture, because there are different grades of sprain, and it could be just a uh, partial tearing of the ligaments of the ankle. It could be a larger tear or a complete tear. Um, and so, treatment for ankle sprains typically is an ankle brace just to help immobilize the ankle and allow those ligaments to heal, which can take up to a month to heal. Physical therapy is also important for early rehabilitation to strengthen the ankle and improve range of motion and proprioception. Um, and if there isn't any significant improvement after about 4 weeks, sometimes we have to get an MRI, especially if it's a grade 3 sprain, just to make sure that there's not a full ligament or tendon tears that need to be surgically repaired. So, main takeaways from these, overuse injuries. In talking about prevention, make sure you're wearing good supportive shoe gear. Stretch before after exercise. Be aware of your surroundings. Be cautious of uneven surfaces. Avoid sudden changes in direction, and seek medical attention if you're not able to bear weight. If there is numbness, tingling, um, weakness to the leg, suspicion of a fracture, or if the pain does not improve with rest, those are all red flags that you should see somebody. And several of these conditions, like I mentioned, are easier to treat when in the acute stage. So the earlier you seek treatment, the higher chance of faster recovery. Um, so it is very important. I know with most of our professions, we spend a lot of time walking or standing, and so it's very important to take care of your feet as well. And if you have, some customers or clients that they may ask you for advice, it's good to be able to guide them in the right direction. Um, so I'm covering some other topics that I also commonly see in my practice that you may also see or know somebody that has it, but bunions are very common. People that have bunions, they typically have pain to the great toe joint, which becomes prominent, and it may become a cosmetic concern. A lot of times, patients come in because they're not able to get into shoes. Sorry. Um, and uh, Basically, the treatment for this is wearing shoes that are wide enough to prevent pressure and irritation. Sometimes an orthotic can delay or prevent this deformity from getting worse. And padding, such as a bunion gel pad or a toe spacer, can help. Uh, X-rays a lot of times are needed if uh, patients are interested in surgical treatment or you fail conservative treatment. And the goal of surgery is basically to correct the abnormal alignment of the joint with the goal to help relieve pain and allow for fitting into shoes. There are open and also minimally invasive techniques that are being done to correct for this. And one of the advantages of these minimally invasive technique is that sometimes the recovery can be faster than the what the standard technique of which is opened. Um, Estimate recovery for this is about 2 to 3 months, depending on the type of procedure. And sometimes you are able to put pressure almost right away, depending on the procedure, and sometimes you have to be off your foot for about 6 weeks. Um, Next, very common that you may have seen or somebody that you know may have is toenail fungus. And it's a fungal infection of the toenails, typically caused by a dermatophyte type fungus or yeast. And it can be caused by sharing clippers with somebody that has toenail fungus or walking barefoot in public areas, like swimming pools, locker rooms. Um, Toenail injury can also put you at risk for getting this, or contact with soil or animal droppings that contain fungus. You can see on the picture here that you would see progressive yellow discoloration, increased thickness of the nail, brittleness, and sometimes it can be painful. So it is important to seek treatment. The earlier the better, because it can progress and it can also spread to other toenails. So in terms of treatment, sometimes we do a nail biopsy in office if there is any doubts that it could be fungus. Um, or that it may not be fungus. And it's just indicated to confirm the diagnosis and rule out anything else, such as melanoma, which you can see on this picture, which is a type of malignant skin cancer. Sometimes it could be just trauma to the nail. So it may be you're putting topical antifungal medication on this nail for months and you don't see improvement. It's probably because it's not toenail fungus. Topical antifungal medication is, I always prescribe that, and it usually helps if it's in combination with routine nail debridements or pedicures. Um, Oral antifungal medication is another option, but not everybody's a good candidate for this because it could lead to possible liver damage if you're not a good candidate for taking this. So a lot of times we have to do blood work to monitor your liver enzymes and make sure that it's not causing liver damage. Laser treatment is another good option for this to eradicate the fungus via UV light. Um, and let's see, going hand in hand with the toenail fungus is athlete's foot or tinea. A lot of times people that have fungus may have infection in the skin as well, and vice versa. So it is important to treat both so you can get rid of it. But this condition can cause inflammation, itchiness. You can see peeling of the skin. Sometimes it can cause blistering and malodor. So people that are high risk for getting this condition is if you're in warm, moist environments, such as wearing wet socks and shoes for prolonged time, or sharing contaminated surfaces, such as in locker rooms or swimming pools. So I highly recommend wearing at least a good sandal if you're in any of these public areas or if you are in a hotel and showering. So typical treatment for this is topical antifungal creams, foot soaks. Sometimes oral antifungal medication is indicated for more severe cases. Wearing more breathable shoes and socks, such as moisture wicking socks. Um, Good foot hygiene, just keeping your feet as clean and dry as possible. Antiperspirant spray, disinfecting your shoes. And sometimes antibiotics are necessary if there is concern of an infection. Ingrowing toenails is another very common topic, and I see it in all group ages. I've seen it in babies, I've seen it in adults and older patients. It occurs when the edge of the nail grows into the surrounding skin, and it causes inflammation, pain, and at times it can lead to infection. Typically caused by tight fitting shoes, improper trimming, uh, injuries such as a direct impact from like playing soccer, and treatment may include um, topical antibiotic ointment, massaging the nail fold when it's mild cases, foot soaks, routine pedicures, and when it's something similar to the picture here, it would require partial or complete removal of the toenail. In cases where this condition keeps reoccurring, we do recommend what's called a surgical matrixectomy, which basically will remove the side of the nail and we put acid to burn the root of the nail so that part of the nail doesn't grow back. There is still a chance that it could grow back, but the goal is to be permanent so it doesn't keep ingrowing. And a lot of times, if it looks like there is infection, we also prescribe antibiotics for this. So, and the last topic I'm going to cover is diabetic foot care. It's a very broad and topic, very common um, condition that we see in our office. And diabetes is caused by the body's inability to create or use its own insulin. And insulin helps regulate blood sugar levels, providing energy to body cells and tissues. According to the Centers of Disease Control and Prevention, as of 2021, the prevalence for diabetes in the US is 11.6%, and 22.8% of adults with diabetes are undiagnosed. Uncontrolled diabetes can lead to many complications, and frequently they manifest in the feet first. Um, so some of these lower extremity complications due to diabetes are peripheral neuropathy, Charcot foot, peripheral vascular disease, and ulcerations. Peripheral neuropathy is when the nerves are damaged, and it can lead to numbness, burning pain, tingling sensations to the feet. And it is commonly caused by diabetes, but sometimes people can get this condition even without having diabetes. It can be also what's called idiopathic, meaning there's no known cause. Charcot foot is a complication of nerve damage that can lead to significant foot deformities, such as a collapsed arch, and indirectly result in ulceration or foot wound or foot callus. Um, Peripheral vascular disease is when there's reduced blood flow to your lower extremities due to narrowing of the vessels and calcifications, which can lead to wound healing complications. People that smoke have a double risk factor for this. And ulcerations are very common in this population, and it can lead to infection if neglected. So medical attention is highly recommended to prevent worsening infection or complications such as gangrene and even amputation or limb loss. Um, I'm going to show you some pictures next, and the picture here at the upper left, it shows just a test we typically do. It's called a Sykes-Weinstein monofilament test, and that's how we test people to see if they have neuropathy. And people that have neuropathy may not feel any of these points. We test 10 different areas. And so it's a red flag that basically they don't have good sensation. And just because there's no pain doesn't mean that there's nothing wrong with their foot. So it's important to know and get checked for this if somebody that has diabetes. The picture here on the upper right, somebody that has peripheral vascular disease, you will see a discoloration of the skin. There's no hair growth. The skin is going to feel cool. Those are all typical signs of peripheral vascular disease. Picture here on the lower left is somebody that has Charcot deformity. You can see they have a collapsed arch and they have a callus, and sometimes it can lead to a skin breakdown because of the pressure to the foot in that area. The next picture showing somebody that has skin breakdown and some cellulitis or infection in the skin. And then this is a very typical appearance of a diabetic foot ulcer that sometimes they don't even know they have it. They think it's just a callus, but once we go in there, remove the dead skin, there is ulceration. And the earlier you treat these, the better, because it can lead to infection down to the bone, and that's how sometimes people end up needing longer term antibiotics or surgical treatment, which may involve uh, bone biopsy or sometimes resecting the infected bone. So to conclude, a lot of times multi-specialty team approach is often necessary to allow for treatment of diabetic foot infections, healing of ulcerations, and prevent these wounds from reoccurring. So I often work a lot in conjunction with the vascular, plastics, neurology, endocrinologists, and wound care doctors to get some of these, more complex patients healed. Um, it is recommended by the American Diabetes Association for people with diabetes to see a foot and ankle doctor at least once per year or more frequently if indicated to prevent any lower extremity complications. Um, this is a link, and it's from the American Diabetes Association, and it's on tips on how to protect for feet for diabetic patients. And then the link here at the bottom is diabetic foot care guidelines from the American College of Foot and Ankle Surgeons that you're welcome to look over it. It has a lot of useful information. So if you have somebody in your family that may have diabetes, it's really good to know these things, what to look for, and when to seek medical attention, just to keep them out of trouble. So um, that's basically the conclusion of my presentation. Um, I'm hoping I met the objectives. Oh, sure. Okay. Sure. 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 Like down the road. Sure. Yeah. So, I mean, as you can tell, I also like wearing heels, and so what I say is, as long as you're not having pain, you feel like your shoes feel comfortable for you, it's fine to wear them as long as you're not like going like all day wearing them. So I mean, what I'm saying is like going to run errands and doing other things Um, so if you can tolerate that, it's fine. But like you're saying, you may not have symptoms now, but you may down the road. So I always tell patients everybody's kind of on an individual basis. So if you don't have pain, the shoes feel comfortable, because actually flat shoes may not feel as comfortable to you if you have a high arch foot. So you may need something that actually has somewhat of an arch, as opposed to somebody that's flat footed. So everybody's different. So as long as you're not having symptoms, and if you do start having symptoms, then it's telling you really need to look into the shoes that you have, and maybe don't wear them for as long um, of a time. But like I said, everybody is kind of different. But sometimes you don't make those adjustments, or you don't think of that until you start having pain. And so I previously had heel pain myself, and all I have to do if I want to get those symptoms back is go barefoot around the house for longer than 2 hours. So I know you kind of have to know your limits. Sure. Go ahead. I'm sorry, can you repeat that question? So it has to do, because sometimes if your calves are tight, so then once you get them stretched, it loosens. So your calf, your Achilles tendon, it kind of works like a pulley with the plantar fascia. So if it's tight, instead of stretching like it needs to, it pulls on the bone, and it causes all that inflammation if your calves are tight. So sometimes if that is the case, we recommend a night splint. So it kind of holds your foot in that position while you sleep. And sometimes people can't sleep with it, so they just wear it longer during the day. If you're watching TV or you have a desk job, you put it on. So it helps that we don't have that pain after rest. So it comes down to stretching because your muscles are tight. Sure. In my opinion, I think it's more of a marketing thing. I personally don't. The only time I recommend or prescribe splints is after surgery, to kind of hold the alignment and make sure the tissues heal in that position. Um, but just I would say the only way to fully correct the deformity is surgery, unfortunately. Sometimes people use it if you fracture a toe, just to kind of splint it in that position. So it has other indications, but I wouldn't expect to see full correction of the bunion with those things. Yeah. Yes. So it's actually very common. And now that you're asking that, uh, my father, he's in the construction, and he actually just accidentally stepped into a hole like a few weeks ago. And thankfully he didn't sprain his ankle, but he had other injuries. Um, and so it's very common. Sometimes people can just be walking on the curve and they misstep, and their ankle just gives out. And sometimes people have weak ankles just from previous injuries, or just hypermobility of those joints. Oh, sure. So I would say a very common stretch is a calf or the Achilles stretch, where you're touching your toes, or you can use a stretch band to stretch, your calf. You can do some, in and out motion of the ankle, or like doing the ABC, just to help with the proprioception of the ankle. So those are some of the more, I would say, common exercises for your feet. Sure. Sure. So a lot of times we start with physical therapy, because they really, show you more exercises that you can do to help with that. And the key really is being consistent with doing those exercises at home, even once you're done with physical therapy. So I think stretching is probably going to be the best thing, because sometimes you may also have to stretch your hamstrings and higher up, because that can also be the problem, not just your calves. So that is one thing that could help. And then just try to wear shoes that are not completely flat, because that can aggravate it. And other than that, unless it's causing other issues, there are some surgical techniques to help with that. Go ahead. Sure. Good question. So yes. So I'm wearing them right now because I'm presenting. And of course, if you go out to eat or so I would say I do have a limit on the heel. I don't use huge heel, and they have to feel comfortable. But I do bring a change of shoes. So when I go back to clinic, a lot of times I wear shoes that I would show patients what they should be wearing, so that they can. A lot of times they ask me what I would recommend, so I like to show them. And uh, like I said, I kind of know my limits, and so it's okay to wear them as long as you're not having pain or symptoms. And if you do, then it's time to change, and reconsider what it is that you're wearing and for how long you're wearing them. Yes. Okay, good question. So, I like just older version style athletic type tennis shoes if you're doing, you know, uh, running or just your daily activities. Sometimes it can be helpful if you're having pain in your feet. So I like Brooks, I like Asics, I like New Balance. A lot of times it depends on your foot type. So like sometimes people that have more of a lower arch, sometimes they do good with like a Birkenstock, or if they have some like arthritis in their feet. Because if you do have arthritis, sometimes you want a shoe that has a firmer sole that doesn't readily bend. And so a lot of times it comes down to knowing what type of shoe you should be wearing. Um, and if somebody that has a high arch, you're looking for a sandal. Vionics brand is a pretty good brand that sometimes I recommend because they have like an arch incorporated, and they have some house shoes that you can wear, which I'm a fan of wearing house shoes, especially if you're doing quite a bit of walking, or a lot of people are now working from home and they're doing more walking and standing than they think they are. So um, it's kind of a good thing to know, what kind of shoe you should be wearing. And if you already know it's not a great shoe for you, sometimes you can make up for it by wearing arch support. So if you ask me, my least favorite shoes are, I don't like the Vans or Converse. I mean, you can literally bend them in every direction. There's no stability, there's no cushion. And so a lot of times that I have patients come in, they tell me they have foot pain. The first thing I do is look to see what shoes they're wearing. Okay. Yes. The main thing. Oh gosh. Um, I would say it's a pretty good combination of everything that I talked about. I do see, if you're talking about patients I see in the hospital, a lot of diabetic foot infections, foot wounds, some fractures of the foot are very common. In clinic, a lot of times it's heel pain, tendonitis, toenail fungus, um, plantar fasciitis. I mean, those are all very common. I couldn't say there's one single thing. Sure. Well, it depends on how, like what degree of an ingrown. If it's a very mild ingrown where it's literally just hurting at the tip of the nail, and pedicurists, they're trained to do that, it's fine. But if you've tried trimming it, it's still swollen, painful, it's best to see a podiatrist. And sometimes we do have a medical pedicure in our practice for patients that are not diabetic. They don't qualify for a doctor to treat them. And they come in just for routine pedicures. And sometimes if the pedicurist can address it, they still have pain. That's when they send them to us. And anybody that has diabetes, they have to see the doctor first, because sometimes um, there's patients that could have a really bad ingrown, like the picture I showed, and they may not have any pain because they have neuropathy. So their feet are numb, and so it's actually a bigger issue than what they think it is. Sure. 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 So yeah, basically being sanitary is the key for this. You want to make sure that you switch out that bag after every customer client. You're putting in water. All the instruments are really well cleaned, sterilized, because that is a very common. I hear that a lot. Like, oh, I went for a pedicure, and after I noticed my toenails started turning yellow, and now they have concern that they may have caught it at the nail salon. So it's very important that you pay close attention and you're very sanitary. And in terms of the cleaning and just using as good technique as you can to prevent these things. Patients always ask me about what I think. I'm like, it's great. I mean, you can go get pedicures. I rather them get pedicures and have their nails look nice than come to me with huge nails. That it's just I'm okay with that. I tell them, as long as I prefer that they go to the same place, if possible, same person, if they know that that place is sanitary and they haven't had any issues for years. So those are the patients that I tell them it's okay to go back to their nail salon. And then there's some patients that have a very hard time finding one, or they just, some places they just don't want to see them because they see they have significant condition in their nails and they need to be seeking medical attention. So it's good to know who is a good, customer or client, or who may be getting better help somewhere else. It's good to know that. That's it. Okay. Thank you.
Thank you so much for joining us. We appreciate Dr. Arroyo for taking time out of her day to see us. If you have any questions, I'm sure she's happy to answer while she has a little bit of time. But beyond that, have a great day.
Thank you.